Morning, everyone. I'll just start by saying a little bit about myself. I think I probably know quite a lot of people here, or hopefully people know me. I have been a GP in Crewkerne for 23 years now. I've been on the LMC for nearly 23 years. And really my motivation throughout that time has been to try and support both individual GP colleagues but also GP practices in Somerset to improve, survive, thrive, whatever you want to call it, but just helping practices to keep going. And I suppose that's probably what led me to eventually doing the role that I'm currently doing now. And I suppose I started this sort of pioneering thing of having GPs working in acute trusts, where I was Andrew's equivalent in Yeovil Hospital for about 4 years before Catherine took over my role there. And much as Andrew has outlined the really good work that the Alliance are trying to do with general practice, so Yeovil Hospital has been doing the same for quite a period of time. But I'm not going to focus on that in my presentation because I've got 10 minutes, and I'm going to really focus on SHS, which is the company that Yeovil Hospital set up in a slightly different way to what the Alliance has done, and I'll explain a bit about that. So I'll get going. The Symphony Healthcare Services really came about as an offshoot of the Symphony program, which was the PACS Vanguard program that we had in South Somerset that was GP-led, with a board that consisted predominantly of people from general practice. And it was formed in April 2016, so 2.5 years old. And it was really a consequence of some practices in our area approaching the acute trust and saying, we're doing all of this collaborative work with you, and we've been doing that for a period of time, but actually we're struggling and we would like you to consider taking on our contracts. And because I was medical director of the trust at the time, as well as Symphony program chair, that came to me to try and see whether that was something that we should do or could do. As you might imagine, my LMC background, my first reaction was that no, this is not something that acute trusts should do, because acute trusts don't really know how to run general practice. But at the same time, there was a recognition that if we allowed some practices in our area to fail, the impact that that would have on the other practices in our area, and also the impact in terms of activity in the hospital, would be potentially great. And so we set about, I spent 6 months personally talking to people in the LMC, in local practices, in the acute trusts, talking to GPC about the feasibility of doing this and how to do it in the right way, in my opinion. And so what we did was to set up Symphony Healthcare Services, which effectively is an arm's length organization that is technically owned by Yeovil Hospital, but run by people in primary care. And although we have members from the hospital executive team on our board, again, our board is predominantly comprised of people who are from primary care. And so SHS is driven by primary care, but has the support of the hospital. Where we are at the moment is that we started with 3 practices in April 2016. We currently have 10 practices, and there's another one that's integrating next month and another one potentially in January, at which point we'll be at about 88,000 patients. We have a mixture of GMS and PMS contracts. One of the key things that we did when we set up SHS was to say that we needed to preserve these contracts in perpetuity that were so important because they're extremely valuable. And we spent a lot of time developing a charter and articles of association that reflected our vision, which was really about collaboration with all practices, whether they're in SHS or not, but also collaboration with other organizations, so that's community services and the trust. We have a system of a clinical lead in every practice and a practice manager in every practice, and we bring them together into a clinical lead forum, and we use that forum to drive the developments that we want to do in SHS. So we have a vision with various things in it that we set up, and we try very much to hold to those. So the central one for me there is that we are a clinically led organisation led by our GP clinical leads with support from the key other people in our practices who are the practice managers. And there's a whole load of others there that I won't go into because I haven't got time. So what's our aim? What do we want to do? So the key and most important message is that SHS is about trying to keep general practice stable and provide high quality primary care. But mindful of the fact that we are linked to the hospital, it's also about trying to provide services that benefit the whole healthcare economy, not just our own practices. And our ambition is to create a network of practices that work collaboratively together at various scales. So we try and link local practices to work collaboratively together in small localities, but also our ambition is to try and create bigger localities for practices. We have some functions that are centralized. We have all of our practices implement the models of care that were developed in the Symphony program, but so do quite a lot of other practices in South Somerset who aren't in SHS, and so we're not different to them. We spend a lot of time trying to collaborate with all of the other providers of healthcare, and particularly the other practices in our area. We have a member from the non-SHS practices, as we call them, on our board, because in our view we need to be open and transparent about what SHS is doing, and it's just as important for us that the other practices who are in the same localities as our practices know what we're doing, because we don't really have anything to hide, and we feel that there's a lot of work that we can share. Our sort of central workforce plan revolves around having a wider multidisciplinary team and effectively flattening the structure in general practice settings, working both in individual practice level but also in localities. So our aim will be to have multidisciplinary teams that work across practices, potentially where we have small practices where it's not just viable to have a full-time ECP or pharmacist. We employ GPs on, so the GPs that we have, some of whom are former partners, some of whom have come from outside, we employ them, with the exception of one or two people, as what we call employed GPs. Effectively, we incentivize doctors to work like partners historically worked, but for the clinical element that partners provide. So we incentivize people to recognize that they are going to have 12-hour days. They're not going to be doing sessional contracts of 4 hours, 10 minutes, that we expect them to provide continuity for patients. We expect them to get the work done, to support our colleagues, to provide the services that practices need to survive. We like the idea of integrated care, and so we have quite a lot of links with the hospital, and we are in continual dialogue from the hospital with the hospital about some of the services that can be provided by them. As you might imagine, based on what I've just said, we're quite big advocates of the neighbourhood model and the idea of having a wider team that can support our practices to do some of the core work that we feel that we need to do. I've talked about GPs, the sort of employed model that we have. We try very hard to recruit GPs, so we've recruited 24 GPs in the last 18 months. Not a single one of them is full-time, and there is a continual demand for GPs in our practices. And the way that we have attracted them is to try and be as flexible as possible about how we employ GPs. So we have 1 or 2 GPs who just do sessional work for us and will come and effectively be locums in our practices. Often GPs who are wanting to try out our practice to decide which ones they like and which ones like them. Predominantly we try and employ GPs in one individual practice because we need the continuity that those GPs provide. But we have an ambition to try and change how we provide services. So in one locality, in a month's time, in Somerset, we're going to have 4 practices that are within 5 square miles of each other, providing services to about 27,000, 28,000 patients, where At the moment, every practice has an on-call GP and an on-call team, and actually if you were starting from scratch to look at those services, you probably wouldn't provide the on-the-day demand in that way. And so we have ambitions to try and change the way that that's provided. Sometimes our contractual arrangements, because we wanted to keep the individual GP contracts, that gets in the way, because technically you can't see so your patients can't be seen by another practice that has a contract somewhere else, and so we're working with commissioners to try and look at how we might provide enhanced services and even core services in a different way. I've talked about our forums and the fact that we use them to drive some of the vision and our priorities. We've developed some things like clinical support hubs, where we have a prescribing team that covers locality of our practices, so that you were trying to get the economies of scale and also create expertise. Data is something that we're not quite there with yet, but I'm working quite hard on trying to make sure that some of the stuff that we do is driven by data, and one of the things we want to do is try and share not only our data internally, but also share our data with other practices. That's all I've got to say, so thank you very much. If anyone would like to find out more, because obviously it's quite a short time, then there's some information on your sheets about how